Standard HRT is simply topping up female hormones, estrogen and progesterone, as the production gradually falls through the menopause transition. Estrogen is given to manage symptoms of estrogen deficiency. Amongst all the other jobs estrogen does, it thickens the lining of the womb, known as the endometrium, in preparation for the arrival of a fertilized egg. In our menstrual cycle, fluctuations in progesterone maintain a safe thickness of the endometrium. If the endometrium becomes too thick, known as hyperplasia, it's at a risk of developing cancer. Therefore, in HRT, we give progesterone alongside estrogen to keep the lining of the womb thin, thus providing what we call endometrial protection. It's essential that women with a uterus take progesterone alongside estrogen for that endometrial protection. For some women, there are cautions and contraindications to HRT. These are closely linked to the risks of HRT, which we will discuss in more detail in a subsequent video. However, broadly speaking, these are previous blood clots, obesity, previous or current breast, ovarian or endometrial cancer or some family history of these things, liver pathology, blood clotting disorders, recent heart attack or uncontrolled high blood pressure. A detailed history will be taken of such issues to try and establish the best course of treatment for you. So, how do we give estrogen? Well, there are two options for the delivery of estrogen. It's either oral, so tablets, or transdermal, such as patches, gels or sprays that are absorbed through the skin. Oral tablets are absorbed through the liver, which can affect the way the blood clots, which can in turn increase the risk of blood clots. Therefore, that must be avoided in people who have liver problems, clotting problems, or previous blood clots. Oral estrogen, much like the combined contraceptive pill, must be avoided in those in risk factors for blood clots, such as obesity or previous clots, and also migraine sufferers. Oral estrogen gives peaks and troughs of estrogen, which can exacerbate seizures and so is best avoided in epileptics. The upside of oral estrogen is its predictable absorption and the ease of use. Transdermal estrogen, so through the skin, has become the first choice delivery method, mainly because it's safer. There are no increased risk of blood clots with transdermal estrogen. Therefore, it is safe in obesity, in people with clotting problems, in people with previous blood clots. Transdermal also gives a steady state of estrogen absorption, which eliminates those hormonal peaks and troughs, reducing exacerbations of hormonal migraine or epileptic seizures. The downsides of transdermal is in the application, so patches not sticking, leaving sticky residues, gels taking a long while to soak in, and furthermore, some women who just simply don't absorb terribly well, which can prove difficult to get adequate symptom control. As I already said, progesterone is an essential part of HRT to protect the endometrium. However, it's the combination of estrogen and progesterone which leads to a small increased risk in breast cancer. Again, I'll talk more about that in the risk video. Progesterone can be combined with estrogen in a pre-prepared preparation, that's a mouthful, of tablets or patches. The progesterone in these formats tends to be less similar to the progesterone that we would naturally produce in our bodies, which can result in more side effects, similar to those side effects of PMT, so bloating, breast tenderness, irritability. These types of progesterone also pose a higher and more prolonged increased risk of breast cancer. The safer alternative, with a preferable side effect profile, are the standalone micronized progesterones, which are more body similar. One welcome side effect of these is that they are calming and have sedative properties, so they tend to make people more relaxed and tend to improve sleep patterns, which can often be an issue in the menopause. The final option for progesterone protection is a Mirena coil, which puts the progesterone locally in the uterus where it's needed, with very little systemic, so whole body, side effects, This is an excellent choice for women who require contraception and women who suffer with heavy periods. In terms of prescribing of HRT, we tend to start at the lowest dose and we build up gradually as required. It takes about 6 weeks to get some effect for that dose and 3 months to get the maximum effect per dose. Thus, we review HRT doses every 3 months so that we're not increasing unnecessarily. There are 2 different regimes of HRT. So, sequential or continuous. Sequential, from the word sequence, delivers hormones in a sequence which mimics our natural menstrual cycle. This is for women who are still having periods or are within 1 year of their last period. This regime will give a regular monthly bleed. As women progress on this and they're moving further towards being menopausal or their final period, these periods will probably become less. Continuous HRT delivers both estrogen and progesterone continuously. This regime is for postmenopausal women or for women who are more than 1 year past their last period. Women should not bleed with this regime. Unscheduled bleeding on HRT is not uncommon, especially on initiation or with dose changes. But it's important to discuss changes to your bleeding patterns with your clinician. A detailed history of individual risk factors for endometrial cancer will be taken to guide the next steps in terms of management if you are bleeding. In the absence of risk factors, the general rule of thumb is to amend either the dose or the preparation of either hormone, although it's usually progesterone, in order to try and control that bleeding. If bleeding persists beyond 6 months of starting HRT or 3 months of a dose or preparation change, then further investigation is needed. But the take-home message for patients is, if you are bleeding, contact your clinician so that they can take the responsibility for making the decision. Okay, that's all for that.